So good morning, everyone. We missed last 2 weeks because of holidays. I think we're restarting the sessions now. And today, Hemant Kumar from Madurai will be presenting the case, and it is moderated by Professor Harjeet Singh, Professor Venkatrami Reddy, and Professor Sastry will be joining us shortly, I believe. So I think you can go ahead, Professor Harjeet and Professor Venkatrami Reddy.
Yes, sir. Yes, sir.
Yes, Hemant, you can start.
Okay. Good morning, sir. My patient, a 39-year-old female, is a resident of Bangladesh and homemaker by occupation, presented with chief complaints of pain in the right upper quadrant of the abdomen for the past 4 months and a palpable vague lump in the right upper quadrant for the past 3 months and associated with loss of weight and loss of appetite for the last 3 months. History of presenting illness. Patient was apparently already 4 months back when she noticed pain in the right upper quadrant, which is mild, dull aching and continuous type of pain, and it is non-radiating type and is not related to food and not associated with any aggravating or relieving factors. A month later, she noticed a vague, palpable lump in the right upper quadrant while dressing herself, which was not tender to touch. And the lump was initially smaller in size of approximately 3 centimeter, but has now gradually increased to a hand breadth size. And she is also complaining of a loss of appetite and unintentional loss of weight of around 5 kgs in the past 3 months. She had no history of fever, no history of altered bowel habits, no history of hematemesis or no history of melena, no history of jaundice, no history of nausea or vomiting, no history of similar complaints in the past, and no history of any chronic intake of drugs or oral contraceptive pills, no history of early satiety, and no history of previous blood transfusions, and there was no history of any trauma. Coming to the past history, she is a known hypertensive and is on medications for the past 1 year, and she had no other medical comorbidities and no history of any previous surgeries. And personal history, she consumes mixed diet, and her appetite and sleep is normal, and her bowel and bladder habits remains unaltered, and she is not a smoker or alcoholic. And family history, she has no similar history in any of the family members. Shall I summarize it?
Yeah, please go ahead.
Yeah. A 39-year-old female patient is resident of Bangladesh, homemaker by occupation, and not an alcoholic or smoker, with a known hypertensive, presented with the right upper quadrant pain for the past 4 months and lump for the past 3 months, and associated with the pallor and loss of appetite and unintentional significant loss of weight without jaundice or any upper GI or lower GI symptoms. With this history,
So, any other history you would like to know which is missing from this thing which they are given?
any contact with the pet animals, I have to ask, sir.
Yeah, that's one thing. Anything else you would like to know? Good morning, sir. Sastry, sir. Good morning, sir.
Good morning. Good morning.
Good morning, sir. Ramesh, sir. Yeah.
Why you wrote pallor in the summary?
Sorry, sir. Sorry. Sorry,
Yeah,
sir.
Was
you
I
do-
finding? And why you highlighted the OCP intake in your history?
Sir, OCP intake is associated with hepatic adenoma. So she's having a right upper quadrant pain and upper quadrant lump, and she's a middle-aged female. So I would like to ask for the history of any oral contraceptive pills intake, preferably rich in estrogen content. Estrogen pills.
Adenoma causes a significant weight loss or anorexia.
Less likely, sir.
Okay. So, what do you think from the history? Any
Sir,
differentials?
From the history, I would like to offer a differential diagnosis, sir. And since she's having pain and lump in the upper quadrant with loss of appetite and loss of weight, with short duration of symptoms, can be either a carcinoma gallbladder. Second diagnosis will be secondary liver, Third would be hepatocellular carcinoma.
Why did you put first as gallbladder malignancy?
So, gallbladder malignancy in India, it is more prevalent in the northern eastern parts of the country. So Bangladesh, more or less.
But do you think the presentation would be like this in this patient with such a big lump? And have you seen, like they said, it was, literally a fast-growing tumor, no? It was
Yes,
like
sir.
3 centimeters, then it became almost 78
100.
centimeters.
Yes, sir. It has become 100.
So anything benign you would like to think in this?
Sir,
A young lady.
yes, sir. Since she had loss of appetite and loss of weight, I preferred malignancy because rare possibilities will be hepatic adenoma, focal nodular hyperplasia, or it can be hemangioma.
No. So how the hemangioma or FNH will increase in size from within 3 months from small size to large size? How will you define this benign lesion can have a significant increase in size?
If there is bleeding within the tumor, there will be a rapid increase in size.
Okay.
Anything can you think other than the liver lesions, liver and gallbladder, so right upper abdomen?
It can be arising from the mass, can be arising from the stomach, can be arising from head of pancreas, and can be from the duodenum.
But no GA symptoms at all, no?
Yes, sir. But there is no GA symptom. That's why.
Is it possible to have a GI tumor without significant GI symptoms?
That's what pathology it can be like if you're thinking of stomach and all that.
Sir, gist can present without any obvious GI symptoms, but there will be pain.
Any other organ? To have such a large mass of pancreas is unusual without symptoms associated with pressure around.
You have some other organs, no, in that area. What else?
Pancreas.
The pancreas
You
are
already mentioned pancreas, and I gave my reasons why it is unlikely.
Now, I would like to ask you, can you think of any pancreatic mass such size without pressure symptoms to cause jaundice or duodenal obstruction?
Regarding this, SPEN can present.
SPEN is usually the tail of the pancreas, and this is not the age, it's a younger age, isn't it?
Yes, yes.
What in 39-year-old female patient, what would you think of? SPEN, you were very specific with SPEN. You could have used a broader term, no? What could it be?
Cystic neoplasms of pancreas.
Yeah, it can be a cystic neoplasm. We have seen 1 foot size cystic neoplasms, head of pancreas, with no pressure symptoms, with no jaundice, with no portal vein pressure, no duodenal, because it grows slowly, so it doesn't cause all this, especially if it is benign. Of course, once it becomes malignant and it becomes a cyst adenocarcinoma, it will cause. Continue.
Yes.
Do you attach any significance to the pallor? Does any of your possibilities, say secondary liver, HCC, CAGB, would they account for the pallor?
But pallor is in the examination, no?
Examination, sir.
How can you tell in the history unless you have seen it?
Yes, sir. Sorry, sir. Right.
So your third differential was HCC. So what is
Yes, sir.
code for HCC in this case?
Sir, pardon, sir.
So what are the points which are supporting the diagnosis of HCC, and what are the points which are against the HCC in this case?
Sir, patient is having a right upper quadrant mass, a lump with features of loss of appetite and loss of weight.
Doctor, I'll just stop you for a second. You must have seen a lot of HCCs in your life, haven't you? How many women have you seen with HCC?
Rare.
I can't recall the last time I saw a woman with HCC. They're all males. You see? So, would my fellow moderators agree with that quick point? HCC in a woman?
Yes, sir.
Yeah, well, it cannot be a differentiating point, but yes, it is rarer than male.
Yeah, much rarer. I mean, I usually don't think of a differential diagnosis of HCC in a woman. That is,
Would you think of other organs? When I said other organs, you have missed the hepatic flexure.
yeah, that's what I thought you were hinting at, hepatic flexure of
Yes, sir.
colon.
Hepatic.
Yeah, I
Yes.
thought that you were hinting.
Do you think you have any features? Of course, you already gone to examination findings in your summary itself. But then, does it support the hepatic flexure masses?
Sir, but there is no GA symptoms, sir. She's not having any bleeding per rectum or altered bowel habits.
How do you know
like
she's
that.
not having bleeding per rectum? She has pallor. If she has pallor,
In
it could
history,
be an
she's,
insidious bleed. That's how it is
But-
usually
but,
in a right colon.
yes, sir,
They
but
don't say
there-
bleeding PR, but you'll find hemoglobin 4, 5.
What is the commonest presentation of right colonic growths?
sir, anemia with bleeding per.
Well, it may be
But
overt
what is the
or
commonest presentation of
hidden.
hepatic flexure growths? There's a distinct difference between hepatic flexure growths and ascending colon or cecal growths. Ascending colon and cecal growths rarely cause obstruction. But hepatic flexure is usually a stricturing type of growth. Invariably you operate, it's a stricturing growth.
Okay.
And if you feel a mass, it is a motion which is stuck behind the tumor. It's not the tumor itself. Rarely you find a bulky tumor, an adenocarcinoma in the hepatic flexure. So I have given you a hint. What can it be other than that? Yeah, Pradeep has put that fibrolamellar HCC has no sex prediction, can occur in a younger age. But even that I have not seen in a woman. No.
Yes,
Tell.
Shall I proceed with the examination?
Yeah.
Would
go
you
ahead.
like to revise your order based on the current discussion?
Sir.
Or would you like to stick to that?
Sir, I would like to revise, sir.
How?
First diagnosis will be carcinoma hepatic flexure.
Don't do that. Don't do that.
Don't.
See, you've fallen into his trap. He is nicely laid a trap like for a tiger. He covered it with leaves and patak, you fell into the hole. Hepatic flexure is a very unlike. You won't feel a mass
do that.
unless it's a gist.
Because somebody has given a hint. Say you should weigh the points in favor and against in a current situation and then give your sequence. Yeah, hepatic flexure definitely would form the differential diagnosis, but not necessarily the
Not
first
the
one.
first. Unless it's a gist, very rare. Go on.
It
Okay.
could be probably gist of the stomach arising from stomach.
Also
It
it's
could be-
possible, yeah.
Right
then you can explain
hypochondrium.
the
See, the
pallor.
location of the tumor is mass is right hypochondrium.
Yes, sir.
We don't know that. We only know pain is in the right hypochondrium. We don't know where the lump until we examine. Because the patient doesn't describe where the lump is according to anatomical terms. So until you examine, you don't know where the lump is.
Go ahead with the examination.
Okay, sir.
I think if the patient is from the endemic area and the presentation is right upper quadrant lump with pain and significant weight loss, I think
CA
should
gallbladder.
keep CA gallbladder as the first differential.
That's the first. I mean, in endogangetic plane, this should be the first diagnosis. No questions about it.
Okay. General physical examination. She is conscious, cooperative, and oriented. And her height is 157 centimeter and weight is 62 kg. And her BMI is 25.2. And she is well built and nourished. Her performance status is CCUG 1. And her breath holding time was 36 seconds. There is a pallor and there is no icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. And pulse rate was 78 per minute. and the BP was around 130-60 millimeter of mercury, and the respiratory rate is 18 per minute, and she's afebrile. And there is no signs of enlarged left supraclavicular nodes, and there are no signs of liver cell failure. Coming to the abdomen examination, per abdomen on inspection, there is a fullness noted in the right hypochondrium and the right lumbar region, and the umbilicus is central in position and inverted, and all quadrants of the abdomen move correspondingly with respiration, and there are no scars, visible peristalsis, skin nodules or engorged veins, and her hernial orifices, there is no visible cough impulse.
Did you make her sit up?
Sir?
Did you make her sit up?
In supine position, I examined, sir. Then
How
I
can
asked
you
her
tell
to stand
about
up.
engorged? How can you tell about engorged veins in the supine position? It has to be
Ask-
seen in the standing or sitting position, isn't it?
Standing.
Basics of clinical examination taught to you in your MBBS days. The engorged veins in the abdomen, you have to make the patient sit up. So if you have not made the patient sit up and the examiner has seen that, then you will be in trouble in the examination, because you would have said engorged veins and the examiner say, I never saw you sit up. Make him sit up. Okay, and then you will be unnecessarily in trouble. So you should ask the patient one, and she has got normal ECOG one, she can sit up. Make her sit up and see.
And there is no renal angle fullness. On palpation, there is a firm mass felt in the right hypochondrium, epigastrium and umbilical region, and extending into the right lumbar region. Inferiorly, measure about 10 cross 7 centimeter, and it is non-tender, and it has a smooth surface and moving with respiration.
What do you mean about 10 into 7 centimeters? Did you measure it with a scale or with an inch tape? You see, palpation, you have to have it. You have to give us precise dimensions, and the left to right, up to down.
Okay.
You have to give precise.
Yeah, it is.
Dr. Ramesh, they are just given these
Yeah,
findings. They
Oh,
have
they
no
are
more-
given the finding.
Yes,
You have
sir.
not seen the patient. Okay.
They
Yeah.
have not seen it.
But in future, you can tell that. See, you could have earned a brownie point by saying that they have written about, but they should have measured it exactly. In an examination, you should have an inch tape in your pocket and examine it, and don't give it to the other candidates.
And fingers could not be insinuated between the mass and the right costal margin. And on performing leg raising test, the mass becomes less prominent. Rest of the abdomen is soft and non-tender, and spleen is not enlarged, and there are no palpable impulse in the hernial orifice. And on percussion, the upper border of liver dullness is starts at a right fifth intercostal space in the midclavicular line, and there is a dull note over the lump, and the liver dullness is continuous with that of the lump, and the flanks are tympanic nodes. On auscultation, there is normal bowel sounds heard, and on digital rectal examination, the anal tone was normal, no hard nodules felt, and the gloved finger stained with yellow colored stools. Coming to other system examination, cardiovascular system, normal S1, S2 heard, and no murmurs, and respiratory system, bilateral air entry equal.
We can all read the slides, so you don't have to tell this. You can just skip the slide and save 2 minutes. There is nothing in the other system. Go on.
Nothing in the, no
you can
focal
tell that
neurology.
and go on. So don't waste time. Your time is limited.
Okay. So
at the end of it, what is have you changed your diagnosis? Not changed your diagnosis.
I have changed.
What is your diagnosis now?
Can be a biliary cystic tumors.
Sir, it's where is the lesion arising from?
Sir, it's arising
of
from
origin.
Arising, most probably it's looks like arising from liver, sir. It is
Okay.
So
yeah.
So if there was a mass arising of this size from the gallbladder, it will not be continuous with the liver dullness?
Sir, it will not be extending around. It will be continuous, sir, but it won't be involving this much region, sir. It is extending in the from right hypochondrium, involving the epigastrium, umbilical region, and extending to the right lumbar region. And there is
so it's unlikely to be a gallbladder mass size is too big. Okay, I agree with that. Okay. Do you all agree with that?
What you made you
Mm.
think that after examination that initial your differential diagnosis were carcinoma gallbladder and the second was secondary is an HCC. So what is there in the examination so that you have shifted from your diagnosis from HCC and from secondaries to biliary cyst adenoma? And how will you explain pallor and how will you explain a so significant weight loss in biliary cyst adenoma?
Sir, it can be biliary cyst adenocarcinoma, sir.
Yeah.
Second possibility will be a hepatocellular carcinoma, sir. Third possibility,
Is it possible to diagnose a biliary cyst adenoma on clinical examination?
sir, without
What are those?
investigation, we cannot tell it is it's for sure, sir.
See,
With
you are
further-
right in changing your diagnosis to liver. Okay,
Yes,
organ
sir.
of
Yes.
origin. That you are
Yes.
right.
Yes, sir.
But to go to cyst adenoma is not correct.
Yes.
Of the 100 liver tumors you see, 99 are HCCs. So you should have stuck with HCC as Harjeet was telling. You should have stuck with HCC
Okay. Sir.
as your first diagnosis.
Since
If they asked you for a differential diagnosis, then you could have come to cystic lesion, which could be a cyst adenoma, or it could be a hydrated cyst. Of course, in hydrated cyst, loss of appetite, loss of weight is uncommon. But you could have said that.
since she's non-cirrhotic, there's no cirrhotic background, and there is no previous history of any blood transfusion.
Well, you can't get HCC without a cirrhotic background.
Yeah, it can occur, sir. But most commonly, it
So
will
the
occur in the
large
background.
HCCs actually occur without a cirrhotic background. In cirrhotic background, you don't see large HCCs. No, you don't see palpable HCCs. The ones you see are usually on a non-cirrhotic background. I don't know why that is. Can any of the moderators explain why that is? No, it leaves it all puzzled. Okay.
But how do you know that there is no cirrhotic background yet?
There are predisposing factors. From the factors only, I come to a conclusion, sir. She's a 39-year-old female without any
But still, you don't know the viral status.
Yes, sir. Only from history, she is not having any.
Okay, there are no signs of
No, no.
liver cell
No
failure.
signs
But
There is
still,
no portal hypertension because splenomegaly you have not had.
yeah.
Yes, sir.
You should have said that's the first sign you should have said.
Okay,
That
sir.
there is no splenomegaly palpable. So portal hypertension is unlikely. Cirrhosis is usually associated with portal hypertension. You can have cirrhosis without portal hypertension, but usually associated. And one of the signs of portal hypertension is an enlarged spleen.
Okay. Any other differentials you can think? Can you think of hemangioma? Is it possible?
Sir, hemangioma, it's common, sir, but since he is having loss of appetite and significant loss of weight, I could not attribute the symptoms to a benign lesion, sir. That's why I will not offer hemangioma as a differential diagnosis.
I would agree with you. Yeah.
Yeah. Okay.
The loss of appetite and loss of weight turns you towards a malignancy. But then how much weight has she lost?
5 kgs, sir. 5
In?
kgs in 3 months, sir. 3 months she lost, sir. She was around
Because her
60.
BMI is still well preserved.
The performance status is also
well
good,
built
sir.
and nourished.
Yes, sir. Well built and nourished, and his BMI is also
So you have to take the subjective history with a bit of pinch of salt. Because on examination it doesn't reflect.
How will you
Okay,
pallor?
you just keep it in mind that she has lost weight. You have to give respect to it. But
Okay.
then you cannot rule out other possibilities because of this history alone.
Yes. Okay. Sir.
How will you explain pallor with this differential diagnosis? This patient. Because one additional finding you noted was a pallor.
Allergies. Sir, I could not.
If you could have asked the history from the patient, would you ask her something else? What? Woman, 39 years age. Hint. I'm giving you a hint.
Menstrual history.
Yeah, if I were examine the patient, I'll ask her what is the menstrual history like. So she has 5 days heavy bleeding. Then the pallor can be explained by that. So in a woman,
Maybe
you
from
don't
the-
have a history, but that is something that we would have asked if you had the patient in front of you.
Okay.
To explain the pallor
Possible-
and
Sir.
Yeah, go ahead. Now, with the possibility of liver mass, does pallor have any significance? How do you connect these two?
Hepatic adenoma with intratumoral bleeding or rupture can lead to blood loss, and it will present as anemia. It will present as pallor.
Okay.
I would like to ask a set of investigations. First, I would like to do basic blood investigations.
So what is your sequence of possibilities now at this stage?
Sir, I would like to change my potential.
There's
The
no
order of
trap, no trap, mind you.
yes, sir. Sir,
Yeah.
still I think so. In terms of malignancy of any arising from the liver, so can be hepatocellular carcinoma, then biliary cystadenocarcinoma. Then third possibility will be secondary, sir. But I would put it as a last search, since there is a smooth surface of the liver. There is no nodularity seen. And on palpation there is no central umbilication like that. Nothing is seen. So I would like to keep it as a last set of diagnosis. Even though it is a common malignancy in liver, pertaining to this case, I would like to keep it in the last.
Which of the clinical signs is strongly in favor of a liver mass than extrahepatic mass?
Not able to insinuate the fingers between the right costal margin and the mass, and the dullness is continuous with the liver dullness, and the site of the mass corresponds to the anatomical location of the liver, right per quadrant. So I would probably, and such a huge mass of size across, so I would place it liver mass.
Why is not a large gist arising from the distal stomach which has infiltrated into the liver?
Sir, such a mass would have caused compressive symptoms. The patient.
Pallor. You can explain pallor. So what
Yes,
is
sir.
over?
Sir, but for such a huge mass to infiltrate the liver, it would have caused compressive symptoms, and upper GI symptoms should be there. At least there would be early satiety like that. That would be,
Yes.
yes, but this is not having any early satiety or yes, sir.
Okay, with
Yeah, go
the
ahead, Vipin.
possibilities of malignant liver mass,
Yes.
either HCC or biliary cystadenocarcinoma. These are
Yes,
your
sir.
possibilities.
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
So how would you go about investigating this patient?
Sir, I would like to have.
Although I personally do not agree with the biliary cystadenocarcinoma.
Okay,
See, biliary cystadenomas themselves are considered to be rare. Malignant change in that is even, say, it doesn't happen in all and only in 10 to 15% of the patients.
Yes.
So as a clinical diagnosis, one would be hesitant to accept that.
Okay.
Okay, go ahead with your investigations.
So I would like to have complete hemogram first. And her hemoglobin is 8.9, and packed cell volume is 30, and total count is 7,800, and platelet is 2.27 lakh, and she's anemic, sir. Then I would like to have a RFT with serum electrolytes.
Anything else significant in that hemogram?
Hematocrit.
No, whatever is given. Do you think platelet count is important?
Yes, sir.
In
Platelet.
terms of why
Sir,
do you want to know platelet count?
Sir, two possibilities are there. In case of a cirrhotic background, there will be thrombocytopenia, or else in yes, sir.
So it's not only the positive findings, but the negative findings are also important.
Okay, sir. Okay, sir.
So that you should never lose sight of them.
Okay, sir.
Okay. Do they do the PCV by a chart, or do they do actually on a capillary tube and centrifuging? Do you have that knowledge? Pradeep can tell us, because the two don't fit, because normally 8.9 would expect to have about 27, you see. Pradeep is not there. Okay, move on.
Then I would like to have renal function test with serum electrolytes and liver function test with coagulation profiles. So a renal function test seems to be within normal limits. Urea 27, creatinine 0.97, and sodium is 139, potassium 4.3, and chloride is 106. Then I would like to have LFT. Total bilirubin is 0.8 and direct is 0.1, and SGOT is 60 units, and SGPT is 36, and ALP is 172 units per liter. Cell elevated cell. Mind you. And serum albumin is 3.8 and globulin is 3.4, and INR is 1.1. Okay, the alkaline phosphatase seems to be elevated.
What about OT?
So SGOT is also elevated. So, yes,
Yeah,
it's also elevated.
yeah, that's upper, no?
Yes.
See again, any
yes.
important negative
Yeah.
finding?
No, sir.
You would like to see the albumin level and attach some significance to it, whether positive or negative. What is your albumin? Serum
3.8, 3.8, sir.
3.8. So
3.8.
what does it signify to you? Again, as a marker of liver function, you
Liver
must keep
function,
that
sir.
in mind.
Yes, it's a preserved liver function.
Isn't it? It's a very
Yes, sir.
important.
Yes, sir. Preserved liver
So
function.
don't miss that. See, it's not just a routine.
Okay.
You have to view all the investigations specific to the patient in discussion.
Okay.
So you have a liver mass, you are considering HCC, where a cirrhotic background is quite common, and you don't have overt signs of cirrhosis. So you should be looking for indirect signs.
Okay.
Okay.
Then I would like to do an ultrasound abdomen pelvis to look for the
Any
site of
other blood
Any other
test?
blood? Yeah. The blood investigation is complete, or you want anything else?
can go for tumor markers.
Or can go for like what?
What tumor markers?
Sir,
Be
alpha
specific.
fetoprotein. Alpha fetoprotein.
Alpha fetoprotein only.
PIVCA and glycogen. 3 tumor markers I need to do.
Again,
Sir.
don't be biased. See, you have not ruled out secondaries altogether, completely. Still, say any liver solid mass, if it is, we have still no evidence of that. But still, when you are doing a tumor markers, you must do
First membrane condition also.
Yes. Any other blood test you want to do? We've already discussed, say, for cirrhosis or any other background, liver background for HCC, not amounting to cirrhosis.
You have to know the etiology, no? If at all there is some background liver disease.
So viral markers.
Viral markers are crucial, isn't it?
Yes, sir.
Yes, should not miss.
Yes, sir.
See, mentioning all these would give us an idea that you are thinking of this patient, not a routine LFT, nor a routine blood test. This is important impression to give to your examiners.
Okay. And viral markers are negatives. Then I would like to go for imaging, sir. First, I would like to do ultrasound abdomen pelvis to look for the
But you
site
did
of
not this thing, tumor markers, no?
yes. Tumor marker alpha fetoprotein is 23.9. It's elevated.
So any other tumor marker which Sastry sir was asking you want to know?
Carcinomembranous condition I would look for, sir. To look for any that may be secondaries arising from since colorectal malignancies are more common secondaries, I will look for a CEA also.
Okay.
He is not there.
Yes.
what exactly are you looking for in ultrasound to differentiate the possibilities you have in mind? Before we go to the report, just tell us what you are expecting. So in the conditions you are describing, what would be the ultrasound findings?
Sir, I would look for first. I would look for the site of origin of the mass, sir. Paratization, and I will like to look for the echogenicity of the mass, and whether it is having a uniform
In the
echogenicity.
same breath, you can give the significance of what you are saying also. Say, for example, echogenicity, you said.
Yes, sir.
What kind of echogenicity? If it is hypo what, if it is hyper what? I think it's important to, say these things before you go to the report.
Yes.
Hmm.
In case of HCC, it will be hypoechoic.
When you are looking at ultrasound, you are looking at echogenicity, not whether it is HCC or not. So you should describe from the ultrasound point of view, from the echogenic point of view, hyperechogenic what, and if it is hypo what are the possibilities? That is how you would look at an ultrasound.
Cystic lesions tend to be hypoechoic.
Mhm. Okay.
Solid
The
lesions
possibilities you are thinking of.
will be
And then
hyperechoic
the
mass.
possibilities you want to differentiate them from. See, what are the basic SOLs of liver? They could be solid or cystic. Say
Yes,
they are not more than 4 or 5. We are not considering the atypical ones at this stage.
Okay, sir.
So all you are thinking of are hemangioma, a simple cyst, a complex cyst, an abscess, and a solid lesions, benign or malignant.
Malignant, yes.
Isn't it? It's a simple way of thinking.
Yes, sir.
So what would be the ultrasound finding in each of them?
Sir, simple cyst will be it will be uniformly hypoechoic lesion, and there will be no internal septation or debris. There won't be any debris seen. In case of a complex cyst, there may be it is also hypoechoic, but it is not uniformly hypoechoic. But there will be septa will be seen. Septa and internal debris will be seen. In case of hemangioma,
you were thinking of biliary cystadenocarcinoma.
yes, sir. Yes, sir.
So what would you expect there?
Sir,
Again, you have to show that you are concentrating, you are focusing on the patient and
Yes,
your
sir.
own diagnosis.
it will be hypoechoic with associatedly. There may be intramural nodules will be there. There will be thick septa will be there, and the wall will be thicker in case of biliary cystadenocarcinoma. And yes, sir.
And the wall may become irregular.
Yes, sir. Irregular. Sorry,
Yes.
irregular.
The other solid masses you are considering?
Yes, sir.
We are not going to highlight it and other things because of lack of time. So you concentrate on the possibilities you are suggesting yourself.
In case of secondary liver, irregular multiple nodules will be there, irregular, and there will be a foci of central necrosis will be seen. It will be hypoechoic.
Hypoechoic first, yeah. Central necrosis, how would you know if it is uniformly hypoechoic? That is not an important.
Yes.
Okay. What about HCC?
HCC, it will be a heteroechoic mass.
Okay.
And there will be increased vascularity.
Increased vascularity. How do you know if it is hypoechoic? See, any of the liver masses, the most crucial thing is imaging. So you have to have all the imaging findings of the common liver lesions on your fingertips.
Okay, sir.
You must write them down, go revise again and again, and you should be able to rattle them off when asked. You know, that is a crucial thing for liver.
Yes, sir.
What
Yes, sir.
other way of assessing, evaluating a liver mass? It's mainly imaging. Okay.
Yes.
So it's good to have a tabular form of all the common liver lesions with where the findings of the common imaging,
Okay, sir.
ultrasound, a CT, and MR.
MR.
Okay.
Okay, sir.
Okay.
Mm.
Dr.
In
Venkatrami. Yeah, go ahead.
Yeah.
ultrasound, I will also like to look for any free fluid abdomen,
Mhm.
and I would look for any
Yeah. Background
lymph-
status of liver. That's what.
yes,
No?
liver is any altered echoes are there, or and also I look for any lymph nodes, parietic lymph nodes like that. That's also in ultrasound. I will look for all these signs. Then I would
You
You
should
must describe
Yeah.
the liver status. The liver status completely. What would you expect in a cirrhotic liver?
so there will be an altered echo pattern, and there will be nodularity, irregular surface, and nodularity will be there, and it will be shrunken. And the border should will not be sharp.
I think it's
Can,
also
can you, yeah.
mention
Can you get the ultrasound report? Yeah.
it is important to mention the spleen size also when you are seeing the
Yes.
ultrasound.
And the ultrasound abdomen report, the liver is normal in size and echo texture, and there is a large hypoechoic heterogeneous solid lesion seen in the right lobe of liver in segment 5, measuring 7.4 cross 8.8 centimeter, and there is no intrahepatic biliary radical dilatation, and the CBD and portal vein appears to be normal, and the gallbladder is well distended, and there is no any evidence of calculus or wall thickening, and the pancreas visualized portion is normal in size and echo texture, and spleen and kidneys are normal in size and
Rest everything is normal.
no
Rest
evidence of
everything
any
is normal.
yes, sir.
Yeah.
No evidence of any ascites or lymphadenopathy or effusion, sir.
Yeah.
So, ultrasound abdomen reveals there is a mass arising from the segment 5 of the liver, amounting to a dimension of 8 cross 8, 8.8 cross 7.4 centimeter.
Interpretation.
And,
Your interpretation of these findings.
sir, can be hepatocellular.
Hepatocellular carcinoma 1. Okay. Could it be any other benign problem, benign solid lesion?
Can be adenomas.
What would you have expected in an adenoma? The margins of the solid lesion are important, isn't it?
Yes.
In a malignant lesion, you would find them irregular. If
Yes.
it is smooth, you generally consider it as benign.
Okay.
And then
Anything.
it's
Yeah.
largely hypoechoic, heterogeneous, yes.
Yes.
And you would have expected some bleeding if it is an adenoma.
Yes.
Okay, let's go to more important
Yes.
imagings.
So what would you do next after
Sir,
this?
I would like to order a triphasic CT to better characterize the lesions. So I would like to do a triphasic contrast. Next.
Can we have the images? CT images?
Which phase you want to see first?
Sir, first I would like to see a non-contrast phase.
Plain CT.
Yes, sir,
Plain.
plain CT.
Okay. Okay. Anything you want to comment on the plain city?
Yes, sir. There is a huge mass, heterogeneous mass in the involving the segment 4 from 4 and 5.
Segments you can say later, but grossly.
Grossly, it's looking like a globular mass.
Why we
Hmm.
see the plain city? What is the aim of seeing the plain city?
Yeah. That's what you see. What you want to see in the plain city? You have to just mention only that.
Other
Significant.
things you can mention in your venous or
Yeah.
arterial case. What is the aim of doing the plain city?
So when you are seeing the liver irregularity, that's one you can make out. Okay.
Okay.
Then about the mass, anything specific?
Whether
Why
it is
would
homogeneous or
plain city-
heterogeneous, we can see, sir.
Yeah. Anything else? Any calcifications are
Any
important?
calcification, yes, sir. Internal calcifications.
Mass regions.
Yes,
Okay.
yes, okay, sir.
Yeah.
And any. So, the mass.
What do calcifications signify?
Calcification occurs in hydatids, sir.
Is
In
there
this
a
case,
particular
in
type
this,
of calcification?
Sir,
The type
so-
of calcification, does it hint at the diagnosis?
yes, sir. In hydatids, there will be peripheral excel calcification.
but in this case, anything?
Sir,
This is not hydrated, no? Or
yes,
you-
sir. This is not
Okay.
So no
Next.
calcification. Okay, go ahead.
okay, no
Next.
calcification. On plain city, there is a heterogeneous mass involving the segment 5 and 4 of the liver with liver. There is with the liver is seen without any nodularity, or there is no free fluid, and pertaining to the mass, there is a central hypodense. There is a central hypodensity, preferably can be central scars.
Central scar is hypodense. When do you see central scar?
So where do you see?
So in focal nodular hyperplasia, there will be
Adenomas?
adenomas. No, sir. No, sir.
Okay, go to the vascular phase.
Okay. Next phase, what do you want to see?
I would like to have an arterial phase.
Yeah, please. Yeah, what do you see?
Yes, sir.
In the arterial phase, okay.
In arterial phase, there is enhancement of the mass with central non-enhancing areas. There is and also there is a peripheral and it is enhancing from periphery to center.
Do you mean to say it's a progressive?
Yes, sir.
Or centripetal?
Doesn't, huh? Yes.
Sir.
Or is
It
it
looks-
centripetal? So you're saying from periphery to center. So you'll have to give an interpretation also of
Yes,
this.
sir. It is centripetal progress. It's enhancing
Centripetal.
from.
Oh.
Yes, sir.
You're seeing vessels in the periphery? Is there a capsule?
Yes, sir. Well-formed capsule is in visualized, sir.
Where capsule?
Yes, sir. There is a peripheral puddling of contrast seen, sir.
Where?
Sir, in the
You're showing only vessels. Are you
they're,
seeing?
yeah, they're
You are
vessels.
suggesting bleeding there?
not, sir.
What is the pattern of enhancement that you're seeing?
Sir, early enhancement in the arterial phase of this enhancing from
It's not uniform, it's heterogeneously enhancing.
it is
No?
heterogeneously enhancing. Sir.
Yeah.
It's heterogeneously enhancing.
Okay.
More from periphery towards center. It's,
That differentiation, I don't think we can make out. Okay.
okay.
So anything else? So it's there are areas which are not enhancing, no?
Yes, sir.
Hmm.
There are multiple foci of non-enhancing area within that lesion, sir, within the solid mass.
Okay.
Yes, sir.
So what these non-enhancing area signifies?
Sir, areas of necrosis.
So this is the arterial hypervascular lesion,
Yes, sir.
heterogeneous enhancement. What
Yes,
else you want to see?
Want to see the next phase?
There are portal veins
No,
Yeah.
anything else you want to see in
Yeah.
this?
Okay.
in this phase. Sir, there
But
is
just
a
concentrating on this lesion, there can be some other lesions in the liver.
yes,
So
sir.
you should look for the other lesions also.
Yes, sir.
You did
But
not
there are,
mention.
there are no other lesions other than this, sir.
Yes.
So I'll then like to proceed with the portal venous space, sir.
Is it intraparenchymal lesion or exophytic? Go back
Sorry?
there. Just.
Sir, it's intraparenchymal.
Go forward.
The parenchymal, but see that, yeah,
Yes.
come down.
Come down, come down,
Come down.
down further. See?
A lot of
Lot of
exophytic
It
component
is
also.
arising intraparenchymal, but it is
there is a large exophytic component.
exophytic component
Yes.
is also there.
Yes.
Okay.
Then portal venous space, I would look for the washout of the contrast. And tumor looks isodense with the rest of the liver, and there is washout. In portal venous space, it looks isodense with the liver, and there is no washout seen, sir.
Then no loss of what?
There is no washout, sir. It is it looks isodense with the rest of the liver, sir.
Okay.
With the
Without classical washout, would you look for in the portal phase or late arterial phase?
washout will be in the portal phase, sir. Venous phase we have to. With the delayed washout only. In case of HCC.
Why is there a washout?
Sir?
Why is there a washout in HCC?
Sir, HCC is predominantly supplied by the hepatic arteries. So there will be brisk enhancement in the arterial phase, sir. And
No, the question is, why is it washed out? If there is arterial phase, say there are a lot, it's vascular and lot of arteries are there, the contrast should have remained there.
Why there? Yeah. That's typical feature of HCC, no? Why does it happen?
so it doesn't take up the contrast.
It has already taken up contrast.
No, sir.
It's because of the multiple AV communications, AV fistulas within the tumor. Okay. So even in the late arterial phase, you may have a washout.
Okay.
So, it's not delayed washout, it's okay. Go ahead.
Okay, now we can summarize all the findings in all phases, what you have seen, the nature of the lesion, location, the enhancement pattern, everything. Just summarize and then tell what is your differential in this.
Sir, triphasic CT, there is a roughly around 9 centimeter mass in the occupying the segment 5 and 4 of the liver with a heterogeneous mass with early arterial enhancement with a delayed washout, and there is a with a central non-enhancing areas with a smooth capsule, it's encapsulator mass with the exopathetic component with no other lesions in the rest of the liver without any free fluid or paratic nodes and without any dilated intrahepatic biliary radicals, without splenomegaly.
You mean to say there's a washout? You said it was isodens with the
Sir,
liver.
coming lower down, it seems somewhat hypodense than the rest of the liver, portal space.
Okay.
There may be a washout of the contrast from the tumors in portal space. It seems so, sir.
Okay. I think we don't have the delayed films, delayed pictures. I don't think they have it. Okay. This is. This is delayed, eh? Delayed
Yes,
one? Okay. So what you are seeing in the delayed phase then?
Sir, there is washout of the contrast and the tumor is isodense and the central area is still non-enhancing. The peripheries, there is a contrast, irregular.
So what is the aim
Okay.
of CT? We did CT and you explained about the tumor. What else we should see? So one is you characterize the mass and we made a diagnosis. What else we should see in the CT?
Sir, if you plan for major resection, we should look for a future river remnants.
That's one thing, but
City.
you should also see for the other vascular relations.
Yes, sir.
You should see, because this is a central tumor which is sitting on the hilum. So it did not
Yeah.
mention about all these things, and this is very nicely seen in these city pictures.
Yes.
So what is the relation of this mass with the major vessels? So you should also look for the resectability. You
Yes,
should
sir.
thinking about the with the angle of resectability in this patient.
Mass is abutting the right portal vein, but it is not. It's
So where is
infiltrating
left
into.
portal vein? Where is right portal vein? Can you point out? And this is there is a large exophytic component. So what is the relation of this mass with the other surrounding structures?
Sir, it seems to be well encapsulated without infiltration to the surrounding structures, sir.
Portal vein is also splayed. It's not
Yes, sir.
infiltrated,
Yes,
no?
sir. It's played, sir.
Yeah. Okay. I think we are running out of time. What do you think the diagnosis in this? I mean, your probable diagnosis.
Can be hemangioma.
Hemangioma. What are the features of hemangioma? CT.
Hemangioma can be heterodense, but on contrast, there will be peripheral puddling of the contrast with the centripetal progression of the contrast material in delayed phases, sir.
Where is peripheral
Yeah.
puddling or nodular vascularity? Do you see that there? And why should there be a washout?
Here you said there is a washout, no?
Yes, sir.
Then does all this
Does it
fit into
happen?
hemangioma? Hmm?
Sorry.
So what is the classical feature of HCC in CT?
Sir, HCC heterodense lesion with brisk enhancement in the early arterial phase and early washout in the venous phase.
So what happened in this lesion?
So it is enhancing in the arterial phase and it is getting washout in the space.
So why are you saying hemangioma
Sorry.
differential?
So,
Do you think it is typical early washout that you are seeing?
yes, sir. Yes, sir. Yes, sir.
Sastry, sir, your comments on this, sir? Anything?
No, it is not really a classical
Wash.
HCC.
It's
See,
not a
you'll
classical
have to-
HCC thing.
You'll have to look at the whole picture. The surrounding liver doesn't
sir.
appear too cirrhotic. It's a well-defined globular lesion,
Yeah.
not irregular. See, when you're describing a liver lesion, it's important to describe classical, say, what are the facets you are describing? That you should be very clear. The location, the number, and say the margin, go from the periphery to the center. And calcification, and then the surface, density of it, and the effect on the surrounding structures. If there is a central scar. Say there are these 7-8 features which you should go in a sequence. That is important. And when you look at the whole picture, it doesn't appear to be a classical HCC. Okay. So under such circumstances, what do you expected to do. Do you want to take a biopsy?
Sir,
What
in the
other-
absence of, yes, sir, in the absence of a cirrhotic background and suspicious of HCC, I would like to do a biopsy.
Why do you want to take a biopsy, and is biopsy justified? What are the clear indications for a biopsy?
Sir, as I said, in the absence of a cirrhotic background, I have a strong suspicion of hepatocellular carcinoma. I should prove it beyond doubt.
So, no, biopsy is used not only to prove something, but to disprove something
Yes.
else also. Does it make a difference for a solid lesion in the liver? What are you interested in knowing? Is it an operable situation, and the patient is he in an operable state? Isn't it? That is more important. Or your biopsy, is it going to make a change in the plan of treatment? You should
Yes.
consider these. So when you consider these, how do you justify a biopsy here? And what are the dangers of biopsy?
Sir, tumor rupture and bleeding will be there. And
Tumor
peritoneal,
rupture and bleeding, when you're considering adenoma, is real. Then
peritoneal seedling will be there.
seedling, yes. Isn't it? So what in an equivocal imaging possibility of HCC would you do on one imaging?
MRI, contrast MRI.
Yes, another alternate imaging is a reasonable alternative, not a biopsy at this stage. Unless, when do you advise biopsy? See, these principles should be very clear.
Can it be fibrolamellar HCC from the features that you're looking at?
Yes, sir. Pertaining to it has no sex predilection, and from the clinical history and the imaging findings, there is a possibility of fibrolamellar variant, since it doesn't have any sex predilection and it is more common in the younger age group. So
What about no, imaging?
imaging,
From the imaging, can it be fibrolamellar HCC?
there is a central hypodensity
Hmm.
can be attributed to fibro. Yes.
But one thing against is calcifications are
Yes,
not
sir.
there. But
Yes.
usually you get in 3/4 of cases you get calcification, but that is not there. But otherwise, I think features also fit into fibrolamellar HCC.
Yes, sir.
Okay, anything else you can think? Because you don't have it. I mean, it's not a typical HCC, so you have to keep in mind other diagnoses also.
Okay.
Okay. So do we have the findings of CT? Anything mentioned?
Report.
Report?
CT report.
Liver, mild surface irregularity in the left lobe of liver with a prominent fissure, very early CLD, a large well-defined heterogeneous arterial enhancing exophytic lesion with areas of delayed washout and capsular enhancement noted in segment 4B of liver, causing splaying of the right and left portal vein and compressing the right and left hepatic ducts, measuring around 8.6 cross 9.6 cross 13 centimeter with areas of central necrosis. GB is partially distended with edematous wall.
Okay.
No, that's
Everything
okay.
okay.
That's okay, fine. Yeah. Okay. I don't know what.
Have they given an interpretation?
Any impression? Anything is given, sir? What is that?
Yes, sir. Their first impression was HCC, sir, atypical HCC, followed by fibrolamellar HCC.
Okay, followed by fibrolamellar HCC. Okay, fine.
So how do you evaluate the patient now? Now that you have a possibility of HCC or a fibrolamellar variant, what are the options of treatment and how do you evaluate?
Sir, liver function seems to be preserved and the performance status is around 1, and PCLC staging, she is having a single tumor which is single tumor of any size, so it is a early stage, and and bilirubin seems to be normal, and there is no signs of portal hypertension.
So what do you want to do next? Say the obvious alternative, the options of treatment are resection, transplant, non-surgical management, any of these. So
Yeah.
which would you opt and why? And how do you evaluate for each?
Sir, I will go for a resection.
So how do you
Resection.
evaluate? What kind of
Sir,
resection are you planning, and how do you evaluate for the patient for a resection?
Sir, I will look for the FLR of this patient. Sir. I will
Yes,
calculate.
it's important for the volumetry.
Which
That's
FLR
the last next.
resection you want to plan?
Sir,
What resection you want to plan in this patient?
If you want to know the
Left-
FLR, you should know
left.
what you are going to resect, no?
yes, sir. I will plan left hip.
Left.
Yes, sir.
But you said segment 5 is also involved.
So, but in CT it looks segment 4B. I will go for extended left hepatite.
Extended left. Why extended left?
Sir,
If it's only segment 4B is involved, why extended left?
sir, there is a possibility of segment 5 involvement, sir. So I am not sure.
So if the
So-
suppose the segment 5 is involved, so this is extended left or something else you can do. So it's an involvement of segment 4B and segment 5.
Yes, sir. Central. Central.
What else you want to see? In the city, it was written like the early CLD. Do you want to do something else to say that there is no chronic liver disease?
Sir, I would like to do upper G endoscopy and look for any varices.
What else? Fibroscan?
Yes. Yes, sir.
So I think you should do a fibroscan upper G
Okay.
endoscopy, rule out.
Okay, sir. Fibroscan CAP score is 166.
So suppose you want to do a central hepatectomy or left extended, what did we calculate it FLR in this patient?
You should calculate the FLR, sir. Please.
Yes, sir. Can we invite other comments, sir, now?
Yeah, I think we're running out of time. Yes, 9:15 already.
Yes, sir, 9:15, sir.
Yeah.
TD Yadav, Dr. Kapoor, Dr. Deepak. TD.
Morning, Pradeep. Good morning.
Good morning, sir. Good morning.
VK Kapoor here. So a few general points. First is most of the students say there is no past history of similar symptoms. Now, if you have past history of similar symptoms, then it becomes part of the present history. For example, a patient with recurrent biliary colics, patient with recurrent pain of chronic pancreatitis. Suppose the patient is having repeated episodes of pain for 3-4 years, then the history becomes 3 years. What is important is no past history of other symptoms. For example, if you are going to make a diagnosis of gallbladder cancer, whether the patient has history of biliary colics in the past, because the two pains will be different. If the patient you are thinking of is having cholangiocarcinoma, then history suggestive of choledochal cyst or primary sclerosing cholangitis, which is recurrent episodes of cholangitis over a long period of time. If you are going to make a diagnosis of carcinoma head of the pancreas, whether patient has history of symptoms suggestive of chronic pancreatitis in the past. So it has to be separate. It cannot be similar or same symptoms in the past. When you ask for an investigation, you should always add, for example, I would like to get an ultrasound done to look at the organ of origin, the nature of lesion, and so on, rather than just saying, I would like to have an ultrasound, because as soon as you say that, the examiner is bound to ask, what would you like to see? So you should preempt the questions which are going to be asked by the examiner. Most of you make this mistake that when you have described the ultrasound or CT report and the examiner asks, what do you think? And you start saying again, it is a 8 centimeter hypodense mass and all that. No, you don't have to repeat what has already been said. Now what we want to know, what do you think about it? What is your interpretation? What is your possible diagnosis? What is your impression? What the radiologist writes in the end. In CT, there is a difference between a hypodense and a non-enhancing lesion. Hypodense lesion is what you see in the beginning. And then once the contrast is given, whether it enhances, so density is on plane, whereas enhancement is on contrast. In this case, I missed in between, but I don't know whether you described it, because it was a well-defined mass which is splaying the vessels. That is the word the radiologists use. Splaying the vessels, not or displacing them. So all these things suggest towards the possibility of a benign or a slow-growing lesion also. And as was rightly pointed out by one of the examiners, that when you do a CT or an MRI, you not only are looking for the diagnosis, you also want, in case of a malignancy, you want to stage the disease, and finally it is the resectability assessment. So at the end, you have to say that. And on CT, you made a diagnosis hemangioma. I don't think that is correct, because hemangioma has very typical findings. Unless you see peripheral, nodular, irregular, incomplete enhancement, which goes centripetally, you should not make a CT diagnosis of a hemangioma. And last, before that, for liver as well, solid liver as well, I think more and more radiologists today would prefer a contrast enhanced MR rather than a CT. Although we seem to be more comfortable, but they prefer an MR. And lastly, in a patient who is relatively young, who is well preserved, if you cannot exclude malignancy, then you have to resect the lesion, whatever the biopsy report is, and biopsy has its own problems as highlighted by Dr. Sastry. So if it is a possibly resectable lesion, then I don't think most of us would like to do biopsy. Biopsy is if you don't want to resect, you want to prove. But then we all know that no biopsy can prove that a lesion is benign. It can only prove that it is malignant. A negative biopsy doesn't mean that the lesion is benign. So by and large, if it is a solid resectable lesion, most people, unless there is a pressing reason to say that this is the focal nodular hyperplasia or adenoma, most of us would probably like to resect it. So students, please send me a mail, vkkapoor.india@gmail.com, write liver in the subject of the mail. Thank you.
Reddy?
Yes, sir. Good morning. Most of the comments has been taken and explained. I can only say that as Dr. Ramesh sir was saying about HCC in females, I think in exam you cannot be so confident about saying that. And if there is a background of CLD, even females can have HCC, and we have resected. I resected two in last month. So that is one. And second, as CT scan, all those points has already been discussed, and I don't think biopsy will be required in a resectable lesion. So that is what I want to say. Thank you, sir. Most of the things I wrote, but the secondary diagnosis was not made by the resident on the exam, after examination also. Secondary is the commonest liver lesion. Until unless with unknown primary, until unless you are doing a CT scan and excluding everything, even then sometimes we are not able to say from where the secondaries has come. So I think should have come in the one of the differentials after examination. Thank you, sir.
Deepak, any comments?
Yeah, I just want to say that all these histories and everything are given a day prior, and usually, like in this sort of a patient, we should always think of all the possibilities rather than just one or two. Like the colonic thing, hepatic flexure thing came out after a lot of hint which was given, and then it was suddenly shifted to the first diagnosis. I don't think we should be so casual about these things. I think we should clearly identify and give our diagnosis clearly rather than uh, changing everything. Otherwise, most of the things have been covered already.
Yeah, just one more point what GD said, that I also agree that gender, where the patient lives, and personal history like smoking and alcohol are not points to be used for making or excluding a diagnosis. They are epidemiological factors. So they are important only for saying that this is more likely, this is less likely. But I don't think for making a diagnosis, these points should ever be used unless it is something very exclusive.
Yeah, I think particularly the liver SOL is very common in the exam. I think all of you should be very thorough. Yeah, Dr. Shastry has clearly put out how to categorize them and in your thought process. And similarly, you should know how to read a CT in a liver SOL. There are standard. You have tables discriminating between the different structures. I think you should, all of you should be very thorough with this because it's just a points. So many times they might not have 100% coincide, but many of the features might be in favor of one diagnosis. Like in this patient, there are some points like the washout is not very typical of this thing, but there are other points which are favoring. So, but all of you should not hesitate to note this. This is an exercise which you have been during your 3 years. All of you must have gone through many of these cases, and I'm sure this is what we expect in the exam also. You should not hesitate to. We are not right always, but you should know all these points. What point you should look for in a CT scan. So any other comments? Otherwise, we can wind up, sir.
Yeah, I think Hemant Kumar, you should go back and revise the imaging findings of HCC and have them at your fingertips. Have a look at many kinds of, say, go back to your radiology department and see all the liver SOLs, solid liver SOLs, and interact with them. It's a very important part of HCC diagnosis or any liver lesion. I think you will not be excused for not knowing the imaging findings or misinterpreting the obvious findings. I think with this, we can call it a day. Thank you all. Thanks.
Thank you, sir. Thank you, sir.
Thank you, Harjeet. Thank you, Professor Sastry. Thank you, Professor Venkatrami Reddy, and thank you all other faculty, Professor Kapoor, TD, and I think Deepak. Yeah.
Thank you, sir.